Hello everyone. Now I'll discuss question of respiratory system. So we have a 65-year-old man who brought to you with severe shortness of breath for past 12 hours. He has used his albuterol inhaler many times without relief, and we know very well albuterol is a beta-2 agonist. Okay, no effect. He also has low-grade fever that resolved with acetaminophen. He quit smoking 2 years ago but had a 20-pack-year history of smoking, very long history of smoking. Well, low-grade fever is still there and respiratory rate is 22, very high, and he's using SSC muscle of respiration. That means he's really in respiratory distress. And that can be further confirmed by on examination shows prolonged expiration with end expiratory wheezing bilaterally. That shows there is obstruction is there. Obstructive airways is there. Well, ABG is done, pH normal, CO2 low, hypoxia. CO2 is high and bicarbonate low. Well, if I ask you one question, what is the acid-base disturbance in this? It is a case of compensated. Why? pH is normal. Respiratory acidosis, 57 CO2. With metabolic alkalosis, bicarbonate 32. So we can at least guess it. The patient has respiratory acidosis that has been very well taken care of by the kidney in the form of metabolic alkalosis. Well, as the patient is in respiratory distress, immediately he is brought to emergency and non-invasive positive pressure ventilation is initiated. What are the additional therapies that we can most likely to benefit the patient? Well, lovely question. Let us see what's the answer. The answer to this question is methylprednisolone. Well, this patient is 65 years. Elderly person. He has acute respiratory distress. How can you say like this? Respiratory rate is 22. Using accessory muscle of respiration and show prolonged expiration with end expiratory wheezing bilaterally. Hypoxia, CO2 is only 64 millimeter of mercury, and pack year smoking 40 years, pack years. That means he's a case of COPD because of smoking, and now acute exacerbation because this problem is only for last 12 hours. 12 hours is the problem, and patient is in distress because of increased respiratory rate and use of accessory muscle of respiration. Well, low-grade fever suggests the patient had a upper respiratory tract infection. Even still now, the temperature is slightly on the upper side of normal. But remember, he had a low-grade fever and he has taken paracetamol, which really controlled the fever, but still little bit is there. Let us see what are the nice guidelines about acute exacerbation of COPD. The cardinal symptoms are increased dyspnea, which is there in our case. Increased cough, more frequent and severe. Fortunately, it is not there in our case. Sputum production change in color or volume, and this again not there in our case. The one finding is increased dyspnea. Now, what are the guidelines? How to manage this case? Management include oxygen target, that oxygen saturation should be in the range of 88 to 92%. And in our case, it has been done by non-invasive positive pressure ventilation. Inhaled bronchodilator, patient already has taken albuterol inhaler, but it didn't work. Systemic steroid are the one which are again very important in the management. Definitely, we like to consider this in the option. Antibiotic if two or more than two cardinal symptoms are there, but in case only dyspnea is there, that only for last 12 hours, as far as there is no cough, no sputum in the question. So, well, we can give if oseltamivir, if there is some evidence of influenza which is not there. So we give NPPV if ventilative failure, and it has already been done in our patient. And tracheal intubation even if this fails. Now, this is the guidelines. But definitely, Out of all these, what is left here is 6 mg steroid if you go by even rule out technique also. So let's see option E, which is the correct answer, steroids, how they are going to benefit in a case of COPD. They decrease inflammation associated with CO2 exacerbation. And thereby they improve lung function and hypoxemia. Definitely when they are going to reduce inflammation, they're going to help improve lung function. So now when we use this in acute exacerbation, they decrease risk of relapse. Treatment failure and length of hospital stay is reduced. So it has definitely a good beneficial effect on acute exacerbation of COPD. Well, it is given for 5 days. It can be given oral also, or maybe by IV. In our case, it is being given intravenous. But one thing is very important. Whether you give intravenous is more commonly used in exacerbation, but it is equally effective. Even oral is equally effective. If due to any reason intravenous is not possible, you can give orally also. Same dose, it is equally effective. Now let's look into other option. Aminophylline, methylxanthine like aminophylline, theophylline, they cause bronchodilation. They use in chronic management of patients with uncontrolled asthma or severe COPD is limited due to their toxicity. So it's not used for long term, and maybe in uncontrolled asthma, it's not a very good drug because of toxicity, and they have no added benefit over inhaled bronchodilator and steroid in the treatment of acute exacerbation of COPD. So already we are giving steroid is a better answer, and they don't have any good benefit effect and moreover toxicity. Now, first of all, now I've got 2 questions. Stop the video, write down the answer. What is the mechanism of action of aminophylline and what is the toxicity of aminophylline, which restrict the use, chronic use in asthma and COPD? Stop the video, write down the answer. Well, as far as mechanism of action concerned, they have a more, the mechanism of action is they are phosphodiesterase inhibitor. And toxicity is tremor, arrhythmias, are the dangerous side effect of aminophylline, which really restrict the use. And of course, in some severe cases, it can even induce seizure also. So that's why it's a drug. It's not a very popular drug to be used in these patients. Now, let's look into option C, Zephyrlocast. Again, a question for you. Stop the video, write down the answer. What is the mechanism of action of Zephyrlocast? The answer is a leukotriene receptor antagonist. It is used in the management of asthma. It is not useful at all in the acute management of COPD. So this option ruled out comfortably. What about option D? That is fluticasone inhaler. It's a inhaled steroids. Okay, are used in the long-term management of persistent asthma. They are useful, but in case of long-term management of persistent asthma. In COPD with have relatively advanced disease, these gen may simply reduce exacerbation frequency, improve symptom. Okay, well, but they do not affect mortality or lung function. And they do not play a role in the management of acute exacerbation of COPD. The point what I mentioned here is for those chronic COPD. But in acute exacerbation where it is severe attack is there, then these inhaled are not useful. Only we have to give either oral or we have to give systemic. As I told you, systemic is much more used as compared to oral. Well, if I have to give you day-to-day example that I'm saying that IV are more useful, oral are useful, but inhaled are not useful in acute exacerbation. Can I give you a day-to-day example? Yes, I have very good example. Umbrellas are not effective in heavy rains with strong winds. The picture itself explains. So I hope this beautiful picture will explain to you why inhaled steroids are not very effective in acute exacerbation of COPD. Okay. What about option A, salmeterol? It's a long-acting beta-2 agonist, what we write as LABA. And They are used in the maintenance therapy of COPD. Okay, they are not recommended for acute exacerbation. Definitely for acute exacerbation, we need something which should act very fast. Now I have a question for you. Stop the video, write down the answer. What do you mean by paradoxical bronchospasm? Stop the video. Well, it's a beautiful question. It's a unexpected constriction of smooth muscle wall of the bronchi that occur in the setting of expected bronchodilation. In fact, the word paradoxical means opposite effect. When we are using salmeterol, we expect there should be bronchodilation, but in contrast, there bronchospasm occurs. This is known as paradoxical bronchospasm. This phenomenon is observed with beta-2 agonists containing inhaler formulation, and it is an under-recognized adverse event. What it is said that when you are using this drug, especially inhaler, because they have some other ingredient also, what we call as incipients, and formulation, this excipients, that we add on thing what we add with the drug, they are the one which lead to bronchospasm. Okay, so removal of this excipient, or we can use anticholinergic drug that can help in paradoxical bronchospasm. A quick recap of the last minute revision point, nice guidelines. Acute exacerbation or chronic of COPD. The cardinal symptoms are increased dyspnea, increased cough, more frequent and more severe, sputum production, change in color or volume. Diagnostic testing, chest X-ray which may show hyperinflation, ABG hypoxia, CO2 retention that indicate type 2 respiratory failure. In the management, the target is oxygen saturation to be SpO2 in the range of 80 to 92. This is a target. Inhaled bronchodilator, systemic steroid, antibiotic if 2 or more cardinal symptoms are there. Oseltamivir if evidence of influenza. NPPV if ventilatory failure, and even if it doesn't work, go for tracheal intubation. Thank you very much.